Perfect. Okay. Thank you all so much for coming. My name's G. I'm a doctor. I'm working based out of Cumbria at the moment. Um, and yeah, I'd like to welcome you all to the session. We're going to have a brief chat about STIs and bacterial vaginosis today. So yeah, I'd just like to thank Dr. Medhat Basta and Dr. Emma Winter for helping me verify all the content on the slides, and hopefully you'll enjoy the session. If we could just pop to the next slide. Perfect. So we've got a couple of learning outcomes that we're going to cover today. So we're going to recognise, diagnose and formulate management plans for STIs and bacterial vaginosis. Hopefully you'll be able to understand the process of partner notification and to be able to explain this using patient-friendly language, which is really important, especially for practical exams like OSCEs. We want you to be able to use appropriate guidelines when managing presentations of STIs and bacterial vaginosis, and to be able to confidently take a sexual health history, including risk assessment and safeguarding. And that's kind of a common thread that I'm going to be covering throughout all of my sessions because it's such an important part of all medicine, but especially things like sexual health. Okie dokie, next slide please. Okay, so just a bit of housekeeping before we start. So all my sources and my references and links for all of the images that I use will be in the presenter notes of the slides. So after the session, I'll upload them all to Medall, and you'll be able to access all of those resources. And I've also got together some patient information leaflets and extra resources in those notes as well. Great examples of patient-friendly language, at least at Newcastle, which is where I trained. They really liked in OSCEs if we brought up the concept of offering a patient an information leaflet for any condition really that you discuss. They're just really good basic information, even just for revision. And then obviously with us talking about sexual health, there will be images of genitals within the session. There will be images with discharge, bleeding, swelling. You know, if that's something that you might not feel comfortable with, maybe just step away for this session. I think there's no way that we can avoid it, unfortunately. And then just in terms of language, I might use the words men and women throughout the session. I will try my best not to, I want to use inclusive language, but if that does happen, it's on the understanding that, of course, any condition, regardless of your gender identity, you can be affected by any of these conditions. And it's something to be really aware of in all aspects of our clinical practice. We should be using correct pronouns for all patients. If you're unsure, just ask people and try and be as respectful as possible to all patients. And then if I use these two in any of the slides, AM, AB or AMAB means assigned male at birth and AFAB means assigned female at birth. So I hope that all makes sense. Right, I'm going to just pop my camera off and we'll get on with the teaching. Okie dokie. So the way that this session is going to run is we're going to have a few different cases. I'd really appreciate if you could all just pop answers in the chat. I'm really going to be the only person that sees your responses, so don't be afraid to guess if you're not sure. So case 1 is a 22-year-old female patient presents to her local sexual health clinic with a 2-week history of postcoital bleeding and increased vaginal discharge. She denies a change in smell or colour of her discharge, fever, abdominal pain, rash and dyspareunia, which just means pain during sex. She's otherwise fit and well. She takes the combined pill and she's got no known allergies. She's had 3 sexual partners in the last 6 months who are all male. She had unprotected vaginal and oral sex with all of these partners, and she doesn't know if any of them have had symptoms. Based on the information that we've got so far, if you just pop in the chat what your top differential diagnosis might be for this patient. I'll give you about 20 or 30 seconds. Okie dokes. So thank you all for popping your answers in the chat. So we've had a couple of different options. So we've had PID and chlamydia. both really good options for this patient. So if we just pop onto the next slide. Wonderful. So this patient has chlamydia. So the kind of differences between this and PID, sometimes it's a little bit difficult because PID does have a range of symptoms. Usually patients with PID are a little bit more generally unwell, and really the only thing she's noticed is a change in her discharge, pelvic inflammatory disease, inflammation in the title. Usually patients are a little bit more unwell and usually in quite a bit of pain with it as well, at least from my clinical experience, but definitely something to consider. So chlamydia, one of the most common STIs that you'll see in clinical practice. So it may be asymptomatic in a lot of patients. If it's not asymptomatic, symptoms can include mucopurulent, which just means it looks a bit mucousy and has pus in it, cervical discharge, a friable cervix, which means that when you touch it with, for example, like a cotton swab, it will bleed, post-coital bleeding and intermenstrual bleeding, so basically bleeding after sex and bleeding in between periods. And in male patients, you can have mucus from the urethra or mucopurulent discharge from the urethra as well. And some female patients may have odorless mucoid vaginal discharge, so no pus there, it's just a change in texture. Less common symptoms can include dysuria, so pain when passing water, and deep dyspareunia, pelvic pain, fever, and scrotal pain. So deep dyspareunia, pelvic pain, and fever would be more suggestive of something like PID rather than just a simple chlamydia, but definitely, you know, every patient is different and you can get different presentations within that. Next slide, please. So investigations that we want to do for a patient presenting with chlamydia, our gold standard test, so the test that we really want to be doing if it's available to us, is a NAT. So either you'll do a vulvovaginal swab or a rectal swab or a pharyngeal swab if you're suspecting a patient has chlamydia in their throat. In a patient who's assigned male at birth, if you're suspecting urethral chlamydia, a first catch urine is your gold standard test for that. And in any patient presenting with symptoms suggestive of an STI, we need to do a full STI screen, including HIV and syphilis testing. That point I will bang on about throughout this whole session, but it's really important because if you're suspecting any STI, you might have several at once and not know about it, and especially with things like HIV, which is a long-term health condition, it's really important to pick that up early and get people on appropriate treatment. So treatment for chlamydia, our first line is doxycycline, or you can do an extended course of azithromycin and then a stat dose and then an extended course of that. Safety netting for patients with chlamydia, you need to avoid any sexual contact until both you and your partners have completed the course of antibiotics. It's really important to let them know that because, for example, patients with multiple recent partners, if those partners haven't got tested at the same time as they have, it might take a little while for them to get on treatment and complete their course. So very, very important for them to abstain until everyone has finished their course of treatment. Next slide, please. Okay, so we don't normally do a test of cure for chlamydia, but it's important to do in pregnancy, just with extra risk factors for babies in parents who have chlamydia. If they're not compliant with their treatment, because obviously if they've not taken their full course of antibiotics, they may not have eradicated their chlamydia. In persistent symptoms, so again, we might suspect that either they've taken the full course and it hasn't quite worked, or they might not have taken it properly, and in rectal chlamydia. Risk factors for chlamydia: age under 25, sexually active obviously, new or multiple sexual partners, sexual contact with someone who has chlamydia, having a previous STI and not using condoms. And then complications of chlamydia: epididymitis in patients assigned male at birth, reactive arthritis, ophthalmia neonatorum, which we'll talk about a little bit later on. I've got a picture of it, but essentially it's vertical transmission from pregnant parents to babies, and it causes eye problems in small babies. And then you can get chlamydia pneumonia, which is very rare. I wouldn't worry too much about that one for medical school exams. Increases your risk of ectopic pregnancy, infertility, and then PID is sort of a complication of having an STI for a long time or not being treated on time. Cervical cancer and perihepatitis, again, not very common. Next slide, please. Okay, so we're going to move on to our next case. By the way, if you feel that I'm going too fast or too slow, just let me know, or if there's anything that any of you aren't understanding, just pop a message in the chat and I'll be happy to try and explain things more or in a different way. So, a 17-year-old male patient presents to his local sexual health clinic with a 1-week history of painful urination and purulent urethral discharge. So that's just like pus in the discharge. He's finding it very painful to pass urine and is worried about what could be causing this. He doesn't have a fever, rash, abdominal pain or testicular pain. He recently got into a new relationship and hasn't been tested for STIs in over a year, and he doesn't know when his last partner's STI test was. Based on the information that we've got about this patient, what would your top differential diagnosis for him be? Again, I'll give you about 20 or 30 seconds and then we'll have a chat about it. Okay, lovely. So we've had a few people saying gonorrhea, and that is the correct answer. So if we pop on to the next slide. Could we pop to the next slide if that's okay? Ah, perfect, thank you. So yeah, this patient is presenting with gonorrhea. So the scientific name for the strain of it is Neisseria gonorrhoeae. So this can be urethral, endocervical, so within the cervix, rectal or pharyngeal, and it can be also passed to babies during birth, so that's vertical transmission. So your classic signs and symptoms are mucopurulent urethral discharge, epididymis tenderness or swelling, dysuria, so pain on passing water, lower abdominal pain, increased or altered vaginal discharge, anal or perianal pain, a sore throat if it's pharyngeal, and cervical motion tenderness, which basically just means when you're doing a PV examination, if you're doing a bimanual, so where you've got 2 fingers inside, if you move the cervix around, patients will find that very uncomfortable or painful. And if we just look at the image on the left, that's a really good example of classical discharge in gonorrhea. And it's a really classical presentation to have male patients who really are struggling to pass urine because of the amount of pain they're in. It's really uncomfortable for people, unfortunately. So investigations that we can do if we're suspecting someone has gonorrhea. So again, our gold standard is a NAT. So you can do a vulvovaginal swab, a urethral swab, a urine sample, a rectal swab or a pharyngeal swab as well if you're suspecting that it's in their throat. In symptomatic male patients, microscopy is just as good as NAT and it provides an immediate diagnosis. So depending on all of your experiences in sexual health, I don't know if you've had placements there, but basically every sexual health centre will have a room for microscopy. It's a really good skill to learn if you do get the chance, and I find it very interesting personally. But essentially, if you can get a sample of that discharge, pop it onto a slide, gram stain it and look at it under the microscope. If you all have a look at the photo on the right, what we're looking for is little groups of diplococci, intracellular diplococci, and that's characteristic for gonorrhea. You can do a chocolate agar culture to test for sensitivities. It's kind of been in the news a little bit recently in the past few years. Super gonorrhea is what the media seems to be calling it, but essentially it's antibiotic resistance. And unfortunately, because people are either not getting tested, don't realise that they have it, or are delaying treatment or not taking treatment properly, it means that sometimes it's a little bit harder to treat, so that might be necessary for some patients. And again, a full STI screen, including bloods for syphilis and HIV, is always recommended. We could pop to the next slide. Okay, so you want to take culture swabs before starting treatment, just in case you run into issues, again, like I said, with treating gonorrhea. In uncomplicated presentations of gonorrhea, it's just a single IM dose of ceftriaxone. It's a bit nippy for patients. They might not enjoy it. It's usually an injection into their backside. But it's only one shot and then they're sorted, which is quite nice, rather than having to remember to take a long course of antibiotics. If they have a complicated presentation, for example, if they have PID from having gonorrhea, and as long as they're not pregnant, you can give a 1 gram IM single dose of ceftriaxone and a 2-week course of doxycycline and 2-week course of metronidazole. If they have a complicated presentation, for example, like something like PID, and they're pregnant, they need admission and specialist treatment. That wouldn't be managed in the community just because of increased risk, obviously, in pregnant patients. In uncomplicated anogenital or pharyngeal infection, it's the same as an uncomplicated infection anywhere else. It's that single dose of IM ceftriaxone. Next slide, please. Okay, so safety netting for these patients. They need to avoid any sexual contact until 7 days after they've completed treatment and their partners have completed treatment. So if they've got that 1 shot of IM ceftriaxone a week from then, or obviously if they're on a longer treatment plan, then it's a week from finishing that. Test of cure. So if they're still symptomatic, you need to do a culture at least 72 hours after completion of treatment. And we also do a test of cure in basically everyone with gonorrhea, and we use a NAT to check for cure of the infection there. Risk factors for gonorrhea: age 15 to 24, black ancestry. I'm not actually quite sure why that one's a risk factor. I'm sure there's some interesting background to that. Current or prior history of STI, multiple recent sexual partners, inconsistent condom use, MSM, which just means men who have sex with men. Risk factors of partner, so for example, if you've got a partner who has any of these risk factors, even if you don't, if you're sleeping with them, then you sort of increase your risk as well. And a history of sexual or physical abuse. Complications of gonorrhea include epididymoorchitis, prostatitis, PID, like we mentioned before, infertility, and ophthalmia neonatorum. So again, like we were chatting about with chlamydia, if you just have a look at the picture on the right-hand side, this is what it might look like in babies. And it's just an infection in their eyes from vaginal birth and passing on either chlamydia or gonorrhea through that route. Okay, next slide, please. Fab. So, case 3. We've got a 57-year-old female who presents to her local sexual health clinic with a 1-month history of lumps on her vulva. She noticed one at first, and now there are several scattered around the same area. She describes the lumps to you as pink, raised and squishy, with some that are flatter to the rest of her skin. They're not painful, but she reports occasional itchiness. And she denies a rash, fever, change in discharge, dysuria, malaise and weight loss. She's only ever had one sexual partner, who's her husband, and they've been together for 17 years. Based on the information you've got so far, what would your top differential for this patient be? Okay, so we've had a couple of different options for this one. So we've had, three different options, okay. So we've had genital warts, syphilis and lichen planus. Okay, so all really interesting options. We will be covering syphilis later. This presentation was of genital warts, and hopefully I'll be able to explain the differences in presentation between the two. If we just pop to the next slide. Okay, so genital warts, they're caused by HPV or human papillomavirus, and we'll be going into more detail about the vaccination programme and other presentations to do with HPV in the Obs and Gynae section of the revision session. So I think off the top of my head it's on the 31st of March. So if you want a little bit more information about HPV, we'll be talking about it there. But in this session, I'll just be covering the genital wart side of it. So they can affect anogenital skin, lips, oral mucosa, so inside the mouth, oropharynx, so down further towards the throat, larynx, conjunctiva, and nasal cavity. And like I said, they're caused by HPV, and usually it's type 6 and 11 for genital warts. So if we look at the pictures on the right-hand side, I tried to find pictures with different skin tones because they do look very different depending on the colour of patient's skin. But they can kind of look anything from pink to light brown to really dark brown. They can be flat to the skin, they can be raised, they're usually kind of squishy, but they can look a bit scabby as well. Usually they won't bleed or look raw, and that's kind of one of the ways of differentiating them from syphilis. If you're thinking, oh, I don't know whether it's genital warts or syphilis, I would say the two key things is usually with syphilis. So if you're looking for a chancre, usually it'll be one lesion compared to genital warts, which will usually be several. And syphilis, it's more of an ulcer rather than a lump, so it will look raw and red and a bit irritated. So these are benign growths, so non-cancerous. Investigations-wise, it's usually a clinical diagnosis by a specialist, so you can have these diagnosed in a sexual health clinic by a consultant or a specialist nurse. You can biopsy them if you're concerned that, say, for example, you're seeing some lesions that definitely look characteristic of genital warts and some that are looking like something different, if you're concerned that it might be malignancy. And of course, full STI screen needed. Next slide, please. So you've got a bunch of different options for treatment of genital warts. So you can, if patients are happy to self-apply, you can use Aldara, which is imiquimod, and it's 3 times a week for up to 8 weeks, or podophyll toxin, which is commonly known as Watercon. So it's twice a day for 3 consecutive days, and you do that for 4 weeks. You can also get treatment in clinic. So cryotherapy, it's just really, really cold therapy, and it kills the warts. That's safe to use in pregnancy, which is obviously an advantage. You can laser them, and you can use TCA. So essentially, it's almost like a dilute similar to vinegar, I suppose, is a way to think about it. So it's like a weak acid. That's also safe in pregnancy. And you can use nitrozinc complex, so that's known commonly as Veritop. You can refrain from treating. Like I said, they're benign, they're not cancerous, they don't cause any health problems. Their biggest problem for patients is usually cosmetic, and patients don't like the look of them, and I can understand that. You know, it's a big change for people to go through. They can self-resolve in 6 months in up to 30% of people, so some patients prefer just to see how they go, and they self-resolve. And you can also do surgical excision, which is safe in pregnancy, and also you know, it's quite a quick treatment. You don't have to do several things in several treatments spaced out. You can just have one excision and it's gone. Obviously, though, that comes with other complications, infection, bleeding, scarring afterwards. So, you know, it's risk benefit for every patient. Next slide, please. Okay, so safety netting for these patients. Patient information leaflet is really helpful. Gives them information on transmission and treatment, so they can weigh up what treatment they might like to do, if anything. And they should avoid having sex while being treated for genital warts and use condoms. I mean, that's universal advice for anyone. Risk factors, so intercourse at an early age. The reason for that at least partially, is because now we've got a vaccination scheme in the UK that's given between the ages of like sort of 12 and 13. So if patients are having sex for the first time at a very early age before that they've had that vaccination, they're not going to be protected against HPV at all. Increased number of sexual partners, females aged 19 to 22 and males aged 22 to 26. If you have a partner with lots of sexual partners or if you're immunocompromised. Complications of this include incomplete resolution, so still having some or all of your warts following treatment, and scarring after treatment as well. Next slide, please. Okay, how's everyone doing? Does anyone need a break? We're halfway through at least now. How are people feeling? If anyone needs a break or anything, just pop a message in the chat. I'm happy to do 5 or 10 minutes. If no one says anything, I'll just carry on, if that's all right. Okay, so case 4. A 60-year-old male presents to his local sexual health clinic with a 3-week history of an ulcer on his penis. He describes it as red, raw-looking, well-defined, painless and non-pruritic, so not itchy. He only has one ulcer and has never had anything like this before. He doesn't have dysuria, testicular or abdominal pain, urethral discharge, fever or any other symptoms. His last sexual encounter was with an on-off casual male partner about 6 weeks ago. He doesn't think this partner has any symptoms. So based on the information we have so far, what would your top differential diagnosis for this patient be? Okay, yep, so we've had a few through already saying syphilis, and that's exactly right. Next slide, please. Okay, so this patient has presented with syphilis. So this is caused by treponema pallidum. Signs and symptoms depend on the stage of syphilis that a patient presents with. So primary syphilis is what this patient has presented with, a painless genital ulcer. This is another really important thing when you're differentiating syphilis from other STIs. Their chancre or singular ulcer will be painless. It'll have a clean base and a sharp border. So if we look to the picture on the left-hand side, that's a picture of a chancre. So this patient example, he might have presented with something looking like this. You can also have raised lymph nodes in primary syphilis. Then if we move on to secondary syphilis, you'll get a non-pruritic, so not itchy, maculopapular rash, so that's the picture in the middle. Classically, it'll involve palms and soles, so if you're doing a single best answer exam and you see rash on the palms and the soles, you can almost guarantee that they'll be talking about syphilis. You can also have these snail track lesions in the mouth, so if you look at the picture on the right hand side, it does literally look like a snail track inside the mouth. And you can also have unexplained neurological or ocular symptoms. Then if we move on to early latent syphilis, so this can be asymptomatic normally. Latent syphilis just means that the virus is lying latent. And early latent is within 2 years of first infection. Late latent is exactly the same, so the patient will be asymptomatic, but it's been over 2 years since they were infected with syphilis. And then if we're getting to tertiary syphilis, which is very rare nowadays because thankfully we pick up most cases pretty early, but you can have all different presentations of tertiary syphilis in all different body systems, neurological, ocular, cardiovascular, gummatous, basically any sort of involvement. All right, next slide, please. So, investigations for syphilis. So it's screened for during pregnancy in your booking bloods. If you're just seeing a patient though in clinic, you can do dark field microscopy of a swab from a chancre lesion if they've got one. You can also do a PCR from a lesion, and if you get a negative result from this, it rules out syphilis, so it's quite sensitive. You can also do a serum enzyme immunoassay, so from a blood test. You also need to do a full STI screen, of course. Once you have diagnosed syphilis, you use RPR, so rapid plasma reagent, to measure disease activity and to monitor their response to treatment. So treatment-wise for syphilis, oh, and I forgot to say, sorry, that picture is what treponemes look like on dark field microscopy. So this isn't generally done in clinics because it requires more specialised equipment. But essentially they just look like little corkscrews or spirals, and they will move as well on microscopy. You have to do the microscopy pretty quickly because they are living things, treponemes. But yeah, if you see these under the microscope, that's characteristic for syphilis. So treatment-wise, if you're suspecting early infection or if you've got someone who's a contact of someone with confirmed syphilis, you give them benzathine benzyl penicillin. So it's an IM single dose, or if patients are allergic to penicillin or would prefer not to have an injection, you can also use doxycycline for 2 weeks as a second line. In late latent syphilis, you need to do the same benzathine benzyl penicillin injection, but you do once a week for 3 weeks, which can be difficult for patients. These injections are a little bit uncomfortable from my experience, and usually it'll be split in half the dose, so it'll be 1 in each side of the backside, and it can be a little bit nippy for people. And again, you can use doxycycline as an alternative, and it would be a 28-day course this time. For neurosyphilis, including ocular syphilis, I wouldn't worry about remembering this treatment necessarily. It's more just for interest. I don't think it would come up in medical school exams necessarily, but it's procaine penicillin and oral probenecid for 2 weeks, or you can use ceftriaxone IM or IV for 2 weeks plus steroids. Okay, next slide, please. Fab. Okay, so safety netting these patients. We need them to seek medical attention and take paracetamol if they get a fever, a headache, or muscle aches after antibiotic treatment. So this is called Jarisch-Herxheimer reaction, and it's not super common, but it's definitely a known reaction for people to have after syphilis treatment. And it's essentially just this fevery reaction pretty soon after getting their benzathine benzyl penicillin injections. In my experience in actual sexual health clinics, we'll often ask the patients to just sit in the waiting room for 15-20 minutes, half an hour after they've had their treatment, just to make sure that they're fine in the absolute immediate time after they've had their antibiotics, and then they're welcome to go home. And of course we give them this safety netting advice. So patients need to avoid sex until 2 weeks after that's a typo, until after the symptoms have resolved in primary syphilis, and 2 weeks after their antibiotic course has been completed. And we need to make them aware that future STI screens will reveal that they've had syphilis in the past. So that's very important for them to know, just for future healthcare and for their privacy as well. So risk factors: sexual contact with a person with syphilis, men who have sex with men again, recreational drug use, sex work, and multiple sexual partners, and current HIV or another STI. And complications of syphilis: so you can get congenital syphilis from mother to baby, so that's vertical transmission. Syphilis can also cause miscarriage, stillbirth, or neonatal death in this circumstance, which is why we screen for it in anyone who presents with early pregnancy. And then, like we mentioned before, Jarisch-Herxheimer reaction. So this is acute febrile illness within 24 hours of their antibiotic treatment for syphilis. So you can consider giving them steroids to prevent this. I've never seen that actually being done in practice though. Okay, next slide please. So this is just a really good little infographic. I won't hover over it for too long, but if you're looking for a really nice summary of the stages of syphilis, I thought this one was lovely. All right, next slide please. So, case 5 is a 40-year-old non-binary patient who's assigned female at birth. They present to their local sexual health clinic with a 2-week history of frothy, yellow, malodorous discharge. They have no other symptoms at all. They've had 2 sexual partners in the last 6 months, 1 male and 1 female. They don't know whether either partner has any symptoms, as they were casual one-time partners. On speculum examination, you notice some red spots on the patient's cervix. Based on that information, what do you think your top differential would be for this patient? Okay, yeah, perfect. So we've had a couple of people say trichomonas. If we just pop to the next slide, please. So yeah, this is trichomonas vaginalis. So your classic single best answer question will say either red spots on the cervix or strawberry cervix. That's one of those little buzzwords to keep in mind. That's classic for trichomonas in exams. Not so classic in real life. I read a study that said it's only present in about 2% of patients, so that really interested me because definitely in medical school they bang on about it like it's seen in everyone. If you look at the picture at the top, that's what a strawberry cervix looks like. So again, if you see that image in a single best answer, it's more than likely going to be a question about trichomonas. So signs and symptoms include abnormal vaginal discharge. So your classic presentation is it smells odd or unpleasant, it's frothy and it's yellow in colour. Vulvitis, so inflammation of the vulva. Vaginitis, inflammation or irritation of the vagina. Vulval itching and dysuria. So male patients can present with urethral discharge or dysuria, but they can be asymptomatic as well. Investigations wise, it'll be a vaginal swab, so either a NAT or microscopy, and a urethral or meatal swab for a NAT. And if you look at the bottom picture, what that shows is a trich, is what I've heard them called as a sign. Basically, this is what causes trichomonas vaginalis. You'll see that on microscopy, and similar to treponemes, they are alive, so they have these little flagella. If you have a little look, the little sort of strings sticking out of the bottom, those will wiggle and they will be moving around the slide. It's quite cool if you get to see them in person, because again, you'll only see them for a short while after the swab has been taken because they're living things. Treatment-wise, it's metronidazole for a week. Ideally, it's 500 milligram tablets, but those aren't as available as 400 milligrams. So if those are all we have, those are fine too. And safety netting for these patients to avoid sex for at least 1 week and until you and your partners have had treatment and follow-up for this. Next slide, please. Okay, so test of cure is only recommended if patients are still symptomatic after treatment or symptoms recur following treatment, and it's done 4 weeks after they've started treatment. Risk factors: female, increasing number of sexual partners, low socioeconomic status, and previous STI. And complications can be preterm delivery, low birth weight, and you also have an increased risk of HIV transmission if you've got trichomonas. Next slide, please. Okay, so case 6. A 22-year-old female presents to her local sexual health clinic with 4 days of severe dysuria. She's noticed some red spots on her vulva this morning, which were not there before. They're very painful, and she's now finding it difficult to pass urine at all due to the pain. When you talk to her more, she's telling you she's had a bad chest around 2 weeks ago, which is now resolved. She went to a GP 2 days ago with the dysuria, and they've given her antibiotics for a UTI, but her symptoms haven't improved at all. In fact, they seem to have got worse. So based on this presentation, what would your top differential diagnosis for this patient be? Okay, so yeah, we've had a couple of people say genital herpes, and that's absolutely correct. Next slide, please. Okay, so herpes or herpes simplex. So it can affect skin around the genitals and the mouth, so those are more commonly known as cold sores. If we look at the picture just there, that's an example of what genital herpes might look like. So sort of red, ulcerated, very, very painful lesions on the genitals. Common signs and symptoms are dysuria, lymphadenopathy, so raised lymph nodes, genital or oral ulcers like we've seen in the picture. Fever, that's rare and it's usually only with the first episode. They might have a prodrome, and it's usually a tingling sensation before they get the ulcers, and often you'll see patients who know they have genital herpes who will come in and say that they've had this sort of prodrome, this tingling sensation, and they'll come to access antivirals because they know that they're about to get an episode. Primary and reactivation episodes, so first and subsequent episodes often happen after a viral illness, or being under the weather, or being under stress is another common one. You commonly see people who have moved house recently, or been through exams or some sort of other stress, and either they didn't know that they had herpes before and they've had a first episode, or they've had a reoccurrence of it. Investigations wise, it's often a clinical diagnosis based on history and exam. If you get a presentation like in the case example, that's a very, very classic presentation, and just to make you all aware, more for clinical practice than for exams, it's quite common that people will get misdiagnosed with a UTI before they get the ulcers, and I've seen a couple of female patients, and unfortunately they were in a lot of discomfort, and I've even had a patient who had to be catheterised because of the amount of discomfort she was in, and she couldn't pass urine at all because of the amount of pain, and she had unfortunately been misdiagnosed with a UTI, and had she been diagnosed correctly the first time, we might have prevented it getting as bad as it got for her. So it's just something to keep in the back of your mind when you're seeing patients who have symptoms like dysuria. Just have a think, could it be a first presentation or a reactivation of genital herpes? It's just something that's useful to think about. You can also do an HSV PCR, so just a swab of the lesions to know whether they have type 1 or type 2 HSV, or if you're not sure about the diagnosis. If you are taking a swab from a patient with herpes, it needs to be from the lesions, and if you can de-roof them, so take the top off them so you get the sort of fluid inside, that's the best option. This is very, very painful for patients though, even to just touch some patients' lesions can be very, very uncomfortable, so if you're going to take a swab, I would counsel them appropriately that it might be uncomfortable or painful, and if they don't want to do it, that's absolutely fine, that's completely their choice. So just something to make them aware of rather than just going in and taking the swab. Okay, next slide please. So treatment of herpes is acyclovir, so an antiviral. 5-day course, you need to start it within 5 days of symptom onset. So again, with the patient that I mentioned before who had been misdiagnosed, unfortunately by the time she was diagnosed with genital herpes, it was past that 5-day period, so she couldn't access antivirals, which was a real shame because they can shorten the course of symptoms. You can also do symptomatic management, so commonly if patients are finding it painful to pass urine, if they either run water, so if they stand in the shower and run water over when they're trying to pass urine, or they pass urine in a bath, that can be very helpful. We can also give them instiller gel, so it's commonly used for popping catheters in, so it's just lubricating gel with a bit of local anaesthetic in. That can be very, very helpful, and paracetamol. You can use a topical antiviral if you've got oral herpes as well, and you can use suppressive acyclovir if you get multiple episodes in 1 year, and that can just either prevent you from getting more reoccurrences, or if you do, it can make them shorter and less severe. Safety netting wise for these patients, they need to seek urgent medical attention if they get dysuria badly enough that they can't pass urine. That's an emergency and they will likely need a catheter. They need to drink plenty of fluids because the more concentrated your urine is, the more it's going to burn when it's coming out, and that's not going to help you when you're trying to pass urine. They need to avoid sex while symptoms or blisters are present, and they need to tell their doctor, their GP or their midwife if they become pregnant and they have genital herpes, because there's a potential that they could transmit it during birth. Another thing to make patients aware of is that treatment is not going to cure their herpes, but it can help manage their symptoms. And another thing that a lot of patients experience is they'll have one really awful first episode of genital herpes and they might never get another one again, or they might only get one more and it might be 10 years down the line. It's really unpredictable. And usually the first episode is the worst, so patients will often be in a lot of pain, unfortunately, with the first episode, and then they might get no symptoms at all for the rest of their life. It's really hard to predict. Okay, next slide. So risk factors for herpes, HIV infection, any sort of immunosuppression, not using condoms, high risk behaviour, so this can include things like a history of STIs, increased number of sexual partners, and early age of first intercourse. And then complications are need for hospitalisation and for a catheter due to severe dysuria and being unable to pass urine. This is rare, but I have seen it. acyclovir resistance, esophagitis, and erythema multiforme. Okay, next slide, please. All right, so just a quick note on partner notification. So this is a really important part of sexual health because we want to prevent more spread of STIs and make sure that anyone who might be at risk of having one is informed of this and can access treatment and testing. So in chlamydia, if you diagnose a patient with chlamydia, ideally you want to notify all partners that they've had within the past 60 days, or if they're asymptomatic, it's the past 6 months. In gonorrhea, if you have a male symptomatic patient with urethral infection, it's all partners in the last 2 weeks, or the last partner that they've had if it's more than 2 weeks ago. And in male asymptomatic patients, or if they've got a non-urethral infection, or in all female patients, it's all partners within the last 3 months. And then in genital warts, if you can advise them to inform their current partners, that's great, but there's no specific timescale because HPV can lie latent for a really long time before people experience warts. Next slide, please. Okay, so in syphilis, if it's primary syphilis, so they've presented like our patient example with a chancre, and it's all partners in the last 3 months. In secondary or early latent syphilis, all partners in the last 2 years. So again, early latent syphilis is asymptomatic syphilis where they've had a infection within the last 2 years. And then late syphilis, so that is tertiary and late latent syphilis. It's lifetime partners and possibly their children as well. In Trichomonas vaginalis, all partners within the last 4 weeks. And then for genital herpes, it's similar to genital warts, so we need to encourage patients to inform their partners if they're happy to do so, but it can lay latent for a really long time, so sometimes it's hard to, there's no specific timescale. The other thing to note with partner notification is if patients feel uncomfortable or unhappy to disclose to their partners themselves, that's completely understandable. We can organise in sexual health clinics for partners to be notified by the clinic without revealing any information about who has tested positive or anything about the person that we're actually treating. Everything's kept completely confidential. So that's something that a lot of people find beneficial if they just give us a phone number or an address for partners if they have that information, and we can organise all of the notification. Okay, next slide please. Okay, so this is our last case of the evening. So you're working in a GP surgery and your next patient is a 25-year-old female. She explains that for the last week she's had very strong smelling discharge and she's worried she might have an STI. Her discharge has not had any change in colour or consistency, and she's been in a long-term monogamous relationship with her girlfriend for 3 years. She denies abdominal pain, rashes, itch, dyspareunia and urinary symptoms. So based on that limited information, what would your top differential for this patient be? Okay, lovely. Yeah, we only had one more condition to cover, and that's absolutely right. So this patient has bacterial vaginosis, more commonly known as BV. Next slide, please. So, bacterial vaginosis is an overgrowth of anaerobic organisms and a loss of lactobacilli. So lactobacilli are present in normal vaginal flora. Losing them and having an overgrowth of these anaerobic organisms can cause your pH to increase. Really important to note that this is not an STI. It's in this session because it fit best with the sort of group of other conditions, but this is not a sexually transmitted infection. So presentation, again for your single best answer exams, the classic will be a fishy smelling discharge. It will classically be thin, white coloured, but it's important to note that 50% of patients that you see with BV are completely asymptomatic and they won't know that they have it. Risk factors wise for this, vaginal douching, being sexually active, menstruation. I didn't realise why this was, but menstruation increases the pH of your vagina, so anything that causes that to happen increases your risk of BV. if you've got an intrauterine copper device, so this is a type of contraception that doesn't use hormones, it's just copper, smoking, and having an active STI. Protective factors, so things that reduce your likelihood of getting BV, are hormonal contraception, consistent condom use, a circumcised partner if you are sleeping with someone who is assigned male at birth. Okay, next slide, please. Fab. Okay, so investigations-wise, you can do what's called the whiff test. So if you combine a sample of the discharge with potassium hydroxide, it will give off a classical fishy smell. But from my experience, you often don't need to combine the discharge with anything. It will often have quite a strong smell in itself. You can also test the pH of the discharge, and if it's above 4.5, it's indicative that they might have BV. And you can also do a gram stain in microscopy, so again, looking at it under the microscope. Classical findings on microscopy are clue cells, so basically these look kind of fluffy, and it's visible in the little cartoon on the bottom of the screen. So they're kind of fluffy looking, and it's basically just skin cells that are covered in bacteria, and you won't be seeing lactobacilli either. Okay. Fab. All right, next slide, please. So you can diagnose and treat BV based on clinical presentation alone in certain circumstances. So those are listed on the right-hand side. So if the person is low risk of an STI, if they don't have any symptoms of other conditions, including STIs, if symptoms have not developed pre or post a gynae procedure. So for example, if a patient has had a sterilisation or a coil insertion and they develop symptoms of BV, it's not enough just to treat them based on presentation. So it's really important to take a thorough history like we do with every patient, just to make sure that you're not missing any of those. If the patient is not postnatal or post-miscarriage, they shouldn't be pre or post termination of pregnancy. If this is the first episode of suspected BV, or if recurrent a previous episode of recognisably similar symptoms. So basically, if this is a classic presentation of BV for that patient, then it's fine to diagnose based on clinical presentation. Or if it's their first episode of suspected BV, and that they're not pregnant. So treatment-wise, it's metronidazole 400 oral twice a day for 5 to 7 days. That's your first line. You don't need to treat BV if it's asymptomatic. If it's not bothering the patient, that's absolutely fine. Safety netting wise, to avoid douching, scented shower gel, any antiseptic, shampoo in the bath, basically anything that can change the pH of the vagina. It's self-cleaning. Really, you only need water. If you really need to use soap, ideally not inside, and it should be unscented and suitable for sensitive skin. But ideally, if they could just use water, that is the ideal. Next slide, please. Fab. So that is us done for the evening. I hope the session's been helpful, and I hope that all the content made sense to everyone. Thank you for getting involved on the chat. It makes the session a lot more interactive, and makes it nice having a bit of interaction from all of you, so I really appreciate it. The QR code on the screen is just a link to a feedback form. I really appreciate it. I'm really keen to kind of tailor these sessions around what you all might find useful. So if you've got any suggestions about things that you might like to see covered to do with sexual health, or I also am the infectious diseases lead, so I'll be doing 2 sessions on infectious diseases as well. So if there's anything you think might be helpful, or if you'd like any advice on foundation, or if you're thinking about a career in sexual health and you want some advice on things you might want to do in med school or in foundation, I'd love to help with that as well. So if there's anything I can help with, just pop it on the feedback form. If you are interested in learning a bit more about microscopy, I've got an article coming out in about a week's time. So that will cover microscopy in more detail. It'll teach you how to do a gram stain, what you're looking for underneath the microscope, how to take a sample and keep it clean, and lots of pictures and hopefully a lot of good information as well. So that will be out on mindthebleep.com. And yeah, thank you all again for listening, and I hope you have a lovely rest of your evening.